All right. Good morning, Dr. Nathan. How are you?
Good morning, Alex. I'm good. How are you?
I'm good. I'm good. Thank you for joining us today. So today we're having a conversation. It's part of our Build What Matters series where we connect with leaders who are doing something, building something that has an impact with FQHCs. Because of the work that you do and the experience you have with FQHCs, we really want to talk about a few things, right? So number one, we want to talk about the access gap that exists outside of the clinic hours, right? Your regular 9 to 5. So there's some gaps there. What happens to patients and providers when the gap goes unaddressed, right? When nothing's actually done about it? And what does after hours care for FQHC patients actually looks like and not general telehealth? So I think there's a misconception that telehealth is just telehealth, but we believe that there's a difference in providing telehealth for the FQHC population. But before we jump in, for those folks that don't know you, you have a really strong background. You actually started in biomedical engineering before going into medicine, which is not common. That's a unique transition there. But help us understand based on that. Tell us a little bit about yourself, and then if you wouldn't mind, tell us about how that experience helped you, or how has that impacted the role that you play today.
Yeah, thanks, Alex. Thanks. I'm really excited to talk to you today. As you know, I'm a family doc. I'm also trained in lifestyle medicine and clinical informatics as well. Early in my journey, I was heading more towards computer science and engineering. I started my bachelor's in biomedical engineering, but I quickly realized that I don't want to work with machines or in front of a computer screen all day. I wanted to work with people. That's where I shifted my focus to medicine. But then you realize now that even in medicine, you're still sitting in front of a computer, but then the systems are not as great as they could be. I've been practicing for over 10 years exclusively in FQHC settings. I worked in several small communities in the Central Valley. You probably know them, Tehachapi, Delano, Wasco, Lost Hills. And, that's where I met the people who needed the help the most. A few years after practicing, I became an associate medical director at this organization. However, this was the first time this position ever existed. So there was
Huh.
a lot to figure out for the first time. A funny story is, after I got this role, I had this office at the corporate building. So it felt like, oh wow, corporate office. But then COVID hit and I never saw that office again. So
That
being
was
a,
it
yeah,
was short lived.
it was short lived, but it's in my mind that I did have it once upon a time. Being a medical director over COVID gave me a very unique perspective on how healthcare should be. It taught me about what being a physician leadership is and who really we work for. We work for the patients and also we work for the staff at our health centers. Now I lead Primetime Telehealth, where my team and we partner with community health centers and we increase after hours care for patients. You did ask me how my engineering background kind of relates to this and how it makes me a little bit different here. Let me just give you like a little thought experiment. Primary care, how we imagine it from back in the days, used to be very simple. We used to have a picture of our minds of a doctor in a town, and maybe with one or two other colleagues and with a few support staff. And this doctor would know you from childhood to adulthood, and they would take care of you, and it's pretty simple. Now primary care is run much more like an organization. That makes sense in many ways because organizations are more scalable, they're more stable, they have more resources available. But the trade off is that workflows and systems become a lot more complicated. I think my engineering background helps me see those systems more clearly. Some systems are obviously intentional and built on purpose, but then there are a lot of systems that are hidden and not so obvious. When you're dealing with physical machines, you can see the parts, you can see how they interact with each other, how they engage. But when you're dealing with moving pieces in healthcare, which are people, they're influenced by so many factors: stress, culture, fear, family, hundreds of other factors. So this experience helps me step back and look at these systems and see the ones that we can see easily and the ones that are hidden.
So you talked about COVID, right? So you had your office, then COVID hit, and you talked about systems. So when COVID happened, then you had to pivot and transition and deliver care in a way that was not common and under a situation that none of us had ever really seen, at least not in my lifetime. I'm sure not in your lifetime. What was that experience like? Going through that process of providing care during COVID, For FQHC patients, can you talk a little bit about what that experience was like?
Yeah. And, this was just a few weeks after I started this position as a medical director. And, this was through a journey where I never imagined myself being in that role. And so there was a lot to learn at that time. But what happened in that time was that COVID stripped away theory. In healthcare, we spend a lot of time planning, theorizing, predicting, and trying to launch something only when it feels fully ready. COVID showed us very quickly that you don't always have the luxury of waiting for perfection. What mattered at that time was simple. What is our mission? What do patients need right now? And what can we safely do today? Of course, you still want to make sure that nothing is unsafe, dangerous, or illegal. But once you cross that threshold, it's okay to launch something that's not perfect yet. It's okay to have multiple iterations. It's okay to redraw the map. It's okay to start with something manual and then automate it later. And, I quickly learned that patients and staff are pretty flexible, more than we give them credit for. As long as they understand what you're trying to build here and what you're trying to do, as long as you communicate with them, it's fine. They understand. They'll be okay with helping you try something new out. But the most important lesson was that if patients couldn't get access, they didn't just politely wait. They got sicker. They went to the
Huh.
emergency rooms, or they disappeared from the system entirely.
So that's during COVID, right?
Mhm.
Like, obviously, the situation was very extreme. No one knew what was going on. Like you said, they couldn't just kind of wait it out, right? Like for some patients, that meant, like you said, going to the ERs. Some unfortunately passed. In today's world, the way we're operating today with telehealth and patients going just to FQHCs, what does it mean what does it mean when the patient can't access their primary care during regular hours, right? So I work, maybe I have two jobs, maybe I have children, or maybe I don't have children, like myself, I don't have children, but I have an elderly mother, right? And I have other things I got to take care of. So just getting to an appointment, whether it be a doctor appointment, any appointment, it's hard to get to for me during the day. What happens to those patients today? Like, talk a little bit about that gap that you see. Like, what ends up happening when those patients say, "I don't have time. I can't make it. I can't take a day off," or maybe some other patients say, "I don't have transportation to get there, and I have to wait for someone to get off work and drive me there." Right. So, how does that impact the patients? What have you seen?
Yeah. We spend a lot of time telling patients that we're their medical home, we're their primary care team, and we're here for preventative care, chronic care, even acute issues too. But as a patient, once you create that relationship, there's an understandable expectation that if I'm calling you my primary care team, I should be able to get the care from you when I need it. But in
Huh.
reality, that's not the case. And it's not about blaming anyone, it's just a reality of staffing and operational issues. From a patient's point of view, the clinic is closed at 5 or 6, and that's when they actually have time to deal with their health. The system is effectively unavailable to them. So what happens next? They go to the urgent care, which is, more transactional. You can see how many urgent cares are popping up everywhere. They go to the emergency room. They Google things. They ask their friends. They ask ChatGPT. They try to self-manage. But then worst of all, they sometimes ignore their issues until the next time they have time to think about it. And by that time, a lot could change. I
Yeah.
think that's where I think people underestimate. When patients repeatedly feel like they can't get access from the team that says it's responsible for them, they slowly stop trusting that team as the center of their care.
So, ultimately, how do you solve for that problem? What would you say?
We're talking about that gap, right? That after hours gap that
Hmm.
doesn't get fulfilled. That gap is there because modern healthcare has changed, but the structure around access and scheduling has not changed. When a physician had a smaller practice, after-hours care was manageable. But now you're talking about health centers that are responsible for 10,000, 50,000, more than 100,000 patients. That's a very different beast. If you want to provide strong after hours internally, you need staffing, scheduling, workflows, coverage, operational support, willing clinicians. And you're asking these individuals to support the service during hours that usually conflict with the exact time that they're trying to spend more time with their family and have their own personal life. So that's what I would say has been a challenge to get these patients that access during those key times.
So this is before my lifetime, right? But way back in the day, I've seen it in movies where like the doctor would carry his little or her little bag, right, and go to the patient's home, and patients laying there sick. And it's interesting to me how that back in the day actually happened. That those things did happen, right? That access was there back in the day, and now that's been gone for
Mhm.
decades. And anyone that does have that access, you have to be pretty well off in order to be able to afford a provider coming to your home. But you said something about the providers being spread thin. And obviously we know we have a shortage of providers. And when I say providers, I'm not just referring to the PCPs, I'm referring to everyone, nurses, PA, everyone. So for those providers that are, let's call it burned out and they're spread thin, right? So on one area, you have these large organizations like FQHCs providing access for tens of thousands of people, in some cases up to 100,000 or more. You have providers that are spread thin. How do you solve for that? And I know this is something you've kind of been able to, not kind of, you've actually been able to figure out is, how are you solving for that? How are you finding providers that want to work in the evenings that are not burned? Like, tell us a little bit more about that.
Yeah, sure. So I kind of want to touch on that providers are spread thin. And I completely agree with that. Providers, especially in FQHC settings, are spread pretty thin. If you're thinking about what a healthy, manageable patient panel is, you can think of value-based care, right? So you're responsible for maybe 400 patients or maximum 800 patients. And this allows you to give, more individualized care, better follow-ups, more touches. But in many community health centers, providers have over 2,000 patients in their panel.
Wow.
And because of cross coverage, they may end up touching the care of 6,000 patients over a few years. Because it's not just my panel, it's a whole ecosystem of patients moving through a large organization. That means that access is already limited. I mean, all these patients need to get appointments. And when patients can't get timely care, they end up using the ER, the hospitals, urgent care, and everything else. Then all of this comes back to the PCP later, but in fragments. Now the provider has to hunt down records, review incomplete information, figure out what
Huh.
happened, and make decisions on pieces. On top of that, the patient is often now medically complicated because they've waited longer to get this care. And the patient becomes more frustrated, disappointed, and angry. So when the PCP is actually now seeing the patient, it's not just the complicated medical situation. There's also an emotional fallout from the delayed care. You can imagine how much that compounds over time.
I never really thought about it like that way. But it is very different to do telehealth for an FQHC or after hours telehealth for an FQ, where you have so many patients, so many moving parts, versus a smaller practice where maybe the doctor has 1,000 patients, right? Or maybe 1,500 patients. She or he knows all of them, right? By their first name. Is there anything else that you say makes it complex for someone, either whether they're doing telehealth internally for an FQHC or after hours telehealth for an FQHC, or if they're partnering with someone like you to do telehealth for an FQHC? What makes it so hard to actually execute that concept?
I mean, you would think it's simple, right? It's a few hours,
Sure.
extend clinic hours schedules. But on the surface, yeah, it sounds like that. Just have a provider log in from home and then schedule them patients. But you still need to manage the clinical coverage. You need medical assistance. You need administrative support. You need to make sure the documentation is flowing properly. And you need to find ways to transition the care back to the PCP. And you're doing all this during a time where you actually don't get much help from the health center because most of their operations have closed. So you need someone to actually own this service. It's not just a side project. If you want high quality after hours care, it needs to be intentional. And with staffing shortage and everything, it's hard to have that ownership internally.
So you mentioned something right now about that continuation of care. And I know from conversations that I've had with some leaders from FQHCs is they are concerned where they think, well, we start offering this and it might replace them actually coming to see their PCPs. But in the work that you've been doing, you've actually seen the opposite, correct? Like you've seen the opposite of that concept there. So can you touch on that and share what your actual findings have been from providing the service to these FQHC?
Yeah, and it's a fair concern because you would think that patients would choose telehealth because it's convenient for them. I mean, that's not a bad thing. It's just, it's convenient for patients, so it's important. And some systems have tried to pull back on telehealth, try to get patients to
Sure.
come in more. But what we've seen, like you mentioned, is the complete opposite. These numbers, their overall numbers have dropped. What we're seeing in practice is that patients who utilize telehealth are not using it in replacement of their in-person PCP visit. These are patients who would have no-showed, they would have delayed care, they would have never booked at all, or they would have gone somewhere else because they couldn't get the care when they needed it. Telehealth, especially after hours, acts as a bridge. It helps patients get what they need in the moment, and then it reconnects them back into the system. If somebody needs acute care now, it does not eliminate the need for their PCP visit 2 or 3 months down the line. These are two different needs. The telehealth visit may be for acute reasons, a refill, follow up from an urgent care emergency department. The PCP visit is still where long-term continuity happens.
You're a unique founder in my view because I've dealt with founders for 20 plus years. 20, I don't even know how long. And a lot of founders build companies based on concept. I have this idea. I think this is going to work. You're different in the sense that you still see patients, right? Not only do you work at an FQHC, but you continue to see patients. So you're in it. You're in the grind every single, maybe not every day you're not seeing patients, but you're there. Why do you do that? Why do you continue to see patients? Because entrepreneurs are always about, hey, I just want everyone else to do the work. I want to relax or I want to focus on other things. Why do you continue to see the patients?
That's who I am. That's what brings me joy in life. You know, you find joy by the work that you do, by the people that you help. And I do this with a passion. I mean, the access is a real problem that I witnessed when I was as a medical director. And so when I increase access, I'm supporting the patients and I want to make sure that my team has all the support that they need. So if the clinic that I support, if they need coverage because someone couldn't make it in or one of their providers calls out, they usually tag me in. And that's where I really enjoy. I like talking to patients. I like hearing their problems. And it's because I know how challenging it is in FQs to manage all these patients. There's a lot going on. Patients are complex. Each one of us clinicians could also get support from each other. So when I see a patient, I talk to the patient about with their care plan, what's going on. I explain things to them. I educate them. And then I send all that information back to the PCP. And some PCPs are very thankful for that because with our documentation, we're able to give feedback as well. And then I see patients who, for example, yesterday, I saw a patient who's been waiting 3 weeks for a refill on a simple medication. They say the pharmacy has sent the medication request to the provider. The provider hasn't had a chance to see it. When they call the clinic, they said the provider has been out. So I've seen those challenges, and I
Uh,
just want to make sure these patients are getting the care that they need while, we figure out building this system.
yeah, that makes a difference. I've used telehealth a few times, and I know for me sometimes it's just been just the fact that I can access someone and have a professional advice on what I'm feeling, and not depend on Google, right? Because a lot of people I feel a certain way. You go to Google, you start searching, next thing you know you have cancer and you're gonna die tomorrow. So having access to telehealth has been great, and I think there's a when we met and you started to explain to me what you were doing, I wonder why hasn't someone else been doing this type of work? So for someone that's not familiar with primetime telehealth, how will you explain, how will you share what you guys do, what you and your team do for these community health centers?
Yeah, yeah, of course. I mean, simply put, we're a medical group. We partner with healthcare organizations and we provide after hours coverage. I mean, that's at the heart of what we do. In practical terms, what that means is we open up a schedule between usually 5 p.m. to 8 p.m., and then sometimes on the weekends as needed. Our providers will see patients on behalf of the health center. We also maintain strong documentation. We have MA workflows. We have, we help patients transition back into their PCP in-person care as well. And we do all this without increasing the burden of the health centers that we partner with. Something else that's unique is because we work with we get really involved with all the community health centers that we work with. So sometimes I act as a medical director. I'll do peer reviews. I'll help with interviews. I'll help with training. And so we learn things from other organizations, and we're able to share that information to help, other organizations that we join with. Sometimes we're able to also provide, I would say, locum coverage, meaning if they have a provider who's going to be out for a week, we do have team members who are able to see patients during the day as well. So we act as that, hey, we need support. Can you guys provide that? And, 99% of the time we can. And that's why I take this very seriously, because if my team can't do it, I'll step in and do it. And I have other providers who are ready to step in and take care of those patients.
So it's not just after hours. It's not just 5 to 9, right? Because I remember the other day we were talking and you said, oh yeah, we jumped in. I think they called you like the day before, 2 days before, and you were able to find a provider to fill that gap. And that's huge. That's huge in so many ways, because it's not only, hey, you have the access now to be able to see that patient, but it's also, especially in today's world, the way FQHCs are operating, every visit that they are not able to see is lost revenue for them. So being able to protect that revenue so they can continue to operate is very important. Now, I know you're trained in lifestyle medicine. So how does that change the way you take care of patients? What would you say how has that impacted the way you deliver care?
Yeah. I love this question because it's actually at the core of what we do. And it's what I think separates us from generic telehealth companies. And it's something that I'm actually very proud of, because with telehealth, you're actually talking to the patient in their home. This is their real environment. This is their kitchen, their living room. They're with their family. This is a place where their habits actually happen. So that changes the conversation. So when we talk about sleep, food, stress, medication, behavioral change, they're hearing it in the environment where these actions actually play out. So in some ways, this is actually more powerful than coming to an office and seeing it separate. So that because you've seen patients when they come into the office, they'll agree with you. They're like, yeah, they totally understand it. But when they go into their real environment, their home, it's a lot harder to kind of apply what they learn. And then they fall back into their bad habits, unhealthy habits.
I never thought about that. You're right, because we act different depending on their setting, right? And we receive things different. So after you start working with an FQHC organization, you've been engaging with them, I'm sure many at the beginning maybe are all for it. We've been waiting for this. We want to do this. Some are, I don't know, let's try it. What will you say are maybe one or two things that some of these leaders from the FQHC have shared with you that they've experienced after working with your organization and continue to work with your organization? What are some of the findings that they've shared with you?
I've seen that health centers see the change in access. They'll see that patients are getting care at a time where they needed that care. And they can see that based on patient satisfaction scores. Even if the health center tries to cut back, the patients would push back. They would say, hey, I know you have telehealth. I've used it before. Why can't I use it? I mean, I thought, in their minds, it could be, I thought the service was made for me. It was super convenient. I didn't have to take time off work. I can talk to my provider when things were more stable with me. Another big impact is continuity. I mean, we're keeping these patients within the same health system in this ideal world where when patients go to different facilities, all this information comes back to you. So we want to keep them within that organization so that the PCPs, the nurses, the staff, everyone still has access to what happened with this patient. And then the last impact has been patient behavior. It kind of goes hand in hand with what I mentioned earlier. If patients know that this service exists, they see the system differently. They might say or think that I know my PCP might not be available, but I know I can use telehealth for now. This gives them a sense of control. And honestly, it's long overdue because in every other part of life, people expect services to be available in a timely way. Everyone else has been offering it. So I don't know why healthcare has to be an exception in this.
You're right. So if I'm a leader from an FQ, how should I be thinking about this, right? For after hours access, is it patient experience? Is it quality? Is it operational? How should where does this fall in, or is it all of them? I mean, what have
Mhm.
you? How will you help them make a decision on how to apply this, or if they should apply this?
Yeah. And you nailed it on the head. You said it's all of them. And I think it's all of them too, because it's a patient experience issue because access shapes trust and reliability. It's an operational issue because poor access creates downstream complexity and fragmentation. And it's a quality issue is because every missed opportunity to engage with the patient, it affects preventative care, chronic disease management, and other quality measures. So really, it's all three. It's the patient experience, the operational issues, and also the quality issues that we're dealing with here.
Yeah, that makes sense. Now, I get asked this question all the time from people that don't work with FQHCs or maybe are starting to figure out what FQHCs are, and their thinking is always like, oh, FQHCs are always struggling. FQHCs are they don't have budget to do certain things, and some of those things are actually true, right? I say FQHCs are the most underserved healthcare organizations that serve the underserved. That's the way I see it. And when you're looking at an FQHC and you're looking at potential changes to telehealth, right? Like there's been almost attempts to roll certain things back on telehealth. And okay, telehealth, you can still do it for this population, but not this population. You can do it for. What will you say happens if in the next few years the government, whoever's in office, decides to start rolling telehealth access back in the sense where, hey, you can't bill for that visit because it's via telehealth. They need to come into the
Yeah.
clinic,
Yeah.
right?
Yeah, for sure. I mean, at the core of it, patients lose access, where and it's the demand doesn't disappear. The
Huh.
demand is still there. They just get help somewhere else. And usually this somewhere else is more expensive and it becomes more fragmented. And that also means that the issues get caught later when they become more complex. So they become more complex and then more resource intensive. And then they try to reintegrate back into the patient's home with all this new fragmented information. And it creates such a mess. So if telehealth cuts back, then need doesn't vanish. We just push it somewhere else. And it's a place that's not ideal for the patient and it's not ideal for the system. There are urgent care services we talked about. The
Sure.
patients will use the ER. Patients will use generic telehealth that doesn't really know the patient, doesn't have their history. And you'll get fragmented care and all this comes back to the FQ that has to handle it.
I remember going into an urgent care and being more upset after going in there than being relieved. I do remember that. And I remember taking my parents a few times and they had no clue who this patient was, right? So they're like, oh, we got to do this, we got to do this, we got to do this, all these questions and what medications. And I'm like, dude, I didn't bring no list of, I should have thought about that. But you're right, it is fragmented. But let's be optimistic. Let's say 3 years from now, 5 years from now, telehealth doesn't go away. Telehealth continues and expands, and God knows how it gets better. We're seeing things in other areas where telehealth is becoming more real and immersive, etc. But let's just say in 5 years, I'm an FQHC leader. I've implemented telehealth during hours, after hours. What does that ideal telehealth program look like for you? In your perfect world for an FQHC 3 to 5 years from now.
Yeah, yeah. I mean, it's just ingrained in the system. Patients have this understanding that this isn't, for example, if we talk about after hours care, patients aren't thinking, hey, this is after hours care. They just know that
Huh.
I don't have to fight for my care anymore. I don't have to call in thinking, oh man, I might be disappointed because might not have availability to see my provider. They know when they call that somehow we're going to get them in as soon as possible, either with their PCP or with telehealth. So they feel they're more in control. They feel like we'll figure out a solution for them because we have service lines available to them. And again, this is where all the other industries have gone. I mean, even as a patient myself, sometimes I have to call my PCP. I don't have an appointment until 6 months down the line. Even as a clinician who's trying to solve this problem, I still face this problem. And that's when I wish this clinic had a telehealth service. And so I take all those learnings of in my own life and my family's life and my friend's life, and I apply it because I can see the suffering that happens. And so 5 years from now, this should just be ingrained. And then also 5 years from now, what I'm trying to advocate is telehealth doesn't have to meet what in-person does every point.
Mm.
Like I said, you can be a little bit more creative with telehealth. That time that you have with that patient it could be used in a different way. You know, when you're in the office, patients need time to get up from their seat. They need time to walk in, get their vitals. You don't have that time, but you can still utilize that time and that effort into something more productive, like talking about lifestyle, like going through their medications, by reviewing their previous history, by looking at preventative care. You know, we could be a lot more impactful with telehealth if we think of it as a separate entity and not just, current replacement for in-person visits.
Let me ask this question. There's a big difference and we experience it in different ways. I say we non-providers. When we start doing a lot of business meetings and everything's Zoom, Teams, da. And it gets, for me, it gets overwhelming. You have 8, 10 different calls every 30 minutes, or, you got to run. I'm just thinking as a provider, there has to be some sort of process and training on how to change that model, right? Because you got to change your way of delivering care, making eye contact, all of that. I mean, have you seen I guess how long does it take for a provider to make that switch if they've only been doing in person to going to telehealth? Because I think still a lot of FQHC leaders say, no, my patients, they only want to come in person, right?
Mhm.
But even for the provider, how long does it take, or what, can you share a little bit like what's the training, or what happens to be able to frame that provider and prep them
Yeah.
to do 20, 30 visits?
Yeah, for sure. And that it needs to be intentional. When you
Oh,
squeeze in telehealth in between in-person visits, sometimes it becomes like a backlog because you have patients waiting in their room and then you have patients waiting on telehealth. So you have from going from room to room, now you have to back away, go to your office, sign on to the telehealth platform, and then see that patient. And so sometimes you can't give that same care because you're thinking about the patients that are waiting. So you don't feel like these patients would mind, because they're at home. So you might end up taking longer to go to them, or you might end up finishing them faster to go back. So it's a little bit more challenging when you try to squeeze it in to in-person visits. But when you
got it.
have it done actually dedicated, like with a schedule, then these providers start to learn what really matters. And you said it, the eye contact, the empathy, the showing the compassion, having that mental space and that time to really talk to the patient, to educate them. And that's for patients, it's for providers who enjoy doing that. Those are the providers who are successful in telehealth because they realize, hey, this is not transactional. This is my opportunity to get this patient thinking about their health. We see a lot of patients, they could come in for a refill on metformin, but to us, what that means is they're actually coming for diabetes management. So this is our opportunity to not only refill the medication, but check on their labs, check on their referrals, make sure they're up to date on preventative care, and make them start to care about their health. And this kind of ties back to, you know, does this reduce in-person visits? It's no, because now we're actually getting this patient into care again. They're
Sure.
thinking about care. They're getting all these other tests done. And eventually they're going to follow up with their PCP with, all these completed. And that just makes everyone happier and healthier.
Yeah. I appreciate, yeah, what stuck with me there is when you said intentional. It has to be intentional. It cannot just be you're just trying to cram it in, and
Hmm.
being intentional even in how you approach the visit, and not just checking the box, right? And
Yeah.
yeah, they're coming in for a refill, but what does this visit really mean? And that makes a difference. So to close things out here, when you hear the phrase build what matters, what does that mean to you in the context of healthcare, business, as an entrepreneur, when you hear those three words, what does that mean to you?
Yeah, yeah. After finding out that's what this show is called, I was thinking about, I mean, why did he choose that? It is very impactful because it means it's kind of what I was talking about before. It means stop waiting for perfect and start building what patients actually need now. And again, this goes back to COVID as well. We already know what matters. Access matters, continuity matters, trust matters. But in healthcare, we often hesitate because we want everything to be built out, fully validated, fully protected, every way possible. And these are obviously understandable because patients' lives matter. Healthcare carries legal, safety, regulatory risk. But if those concerns become an excuse to delay every meaningful improvement, then patients still end up losing. So my how I hear it is build something. Start small if you need to. Start with a pilot. Start with a limited group. Start with something more manually, but start. Let patients use it, watch what happens, learn from them, improve it, iterate. And in my mind, one of the clearest example is access. If access matters, then it's worth building now. And that's kind of what build what matters means to me.
That's awesome. Thank you for sharing that. That's impactful because when we came up with this, someone asked, "Well, what does matter?" And I said, "It's different for everyone, right? What matters is different for everyone. But as long as they're building it and it matters to them, it's the to me that's the most important thing,
And
right?
let them tell you. If it doesn't matter, they'll tell you. But give them that option.
100%. Dr. Nathan, thank you so much. We appreciate it. Thank you for being a part of this. Thank you for the work that you do. It's very impactful. Thank you for continuing to work with FQHCs and community health centers and just helping them improve access to care.
Yeah, thanks, Alex. Your team has been great. I really appreciate all the support that you guys have been providing as well. I'm really looking forward to doing great things with you guys. Thank you.
Likewise. Thank you.